So welcome everyone to this, our 30th Jubilee session, so to say, of Revolutionizing Healthcare. We have been on this for quite a while now, and it's incredible to see the community is still growing every time, and especially having two Tims now on board with us as well on this journey, who will lead us into this session about large language models. Obviously, one of the publicly discussed hot topics of AI and machine learning at this time. So first I want to introduce you to Tim Schubert and Tim Oosterlinck, who will take over the session from here to introduce you to our panelists, and then we will go hear a few talks and contributions from Mihaela and some of our students and research engineers, and go then straight into the panel discussion. So Tims, if you want to take it from here.
Thank you, Andreas, and welcome everyone to this much anticipated session. We have a great lineup of panelists today, and I will just briefly introduce them before they will later contribute a lot to the general discussion. First up, we have Dr. Bill Weeks with us. He is the Director of AI for Health at Microsoft, and we're very happy to have you here today. We're also very grateful to be joined by Dr. Graciela Gonzales-Hernandez. She is the Vice Chair of Research and Education at the Department of Computational Biomedicine at Cedars-Sinai Medical Center. And in addition, we are joined by Professor Eoin McKinney, Professor of Renal Medicine at the University of Cambridge, and he is also a member of the Cambridge Center for AI in Medicine. Thank you so much for being here today, and we look forward to an impactful discussion.
We are also showing some demos of some brilliant PhD students and postdoc students here at the Schaar Lab. And they have created novel tools who will challenge how we look at the implementation of large language models in healthcare. So how will this session work? Tim, you can, yes. We expect this session to be just about an hour, and we want to make sure we have enough room for the discussion at the end. We'll start by highlighting who is joining today. That's what we just did. And then Tim and I will provide a brief introduction into LLMs just to get everybody up to speed. And then we will move on to Professor van der Schaar, who will give her view on LLMs and integration into medicine. We'll then move on to the two demos of today, who will hopefully entice our discussion later on. And after these demos, we'll be moving on to Dr. Weeks, who will tell us about what Microsoft is up to and what his vision is for the future of LLMs in healthcare. And after, we will hear Dr. Gonzales talk about how LLMs can help clinicians interact with the medical knowledge more easily. And finally, we'll move on to the much anticipated moderated discussion. Also, participants, please do ask questions in the chat. It will help us guide the discussion and give us interesting aspects to explore. Thank you very much.
Thanks, Tim. And we're actually going to start with Mihaela.
Okay, so welcome everyone, and thank you so much for coming to this discussion about large language models. As a machine learning researcher, I'm very excited about the emergence of this technology. And what I really hope that we can achieve today is think together out of the box about uses of large language models that have not been talked about so much. So we saw a lot about large language models' ability to maybe think about diagnosis, think about helping clinicians, assisting them in retrieving a certain amount of relevant information from the large available literature. But what I am extremely excited about, and you are going to see some examples of this from our lab later today, is how large language models can create a better interface between conventional AI, which we have been building as a community over many years, and many sessions have been dedicated to this in this Revolutionizing Healthcare, yet are difficult for clinicians to engage with because they may not have the background to really run these different tools and use and capitalize on these different tools. So if somebody would want to interact with, let's say, Autoprognosis 2.0, which is one of the tools that we discussed, for instance, in this series of sessions, or any of the machine learning tools that we highlighted, it would be difficult to do so because the clinician may not have knowledge of Python or of machine learning in general. And yet, with large language models, this interface becomes a lot easier. Really engaging with these different, more conventional AI tools, as well as non-AI tools, tools from biostatistics, tools from other areas that could be very useful for clinicians to really design the future of medicine, become now possible with the use of large language models. So besides the more conventional uses of large language models, I would be very excited to discuss both how maybe clinicians can interface with a larger set of available tools and design really be in the control seat, which I always wanted to do when I started these sessions, and try to kind of push, let's say, this frontier of using AI in medicine. So I like to encourage everyone to really think out of the box, and let's think together. Let's have an interesting discussion thinking about how large language models can really be empowering for clinicians and making them be in the driver's seat of this revolution in healthcare with AI. Thank you.
We will now move on to a very brief introduction to LLMs, as Tim said, just to like get everyone up to speed who's not that familiar with them. So first of all, what is a large language model? Well, we could actually ask a large language model. Could you please explain what you are and like how you function? And what one of the most commonly used and most prominent large language models Chat-GPT gives us is large language models are a type of artificial intelligence system designed to understand and generate human-like nature. And they are basically trained to process vast amounts of textual data. And this is built on deep neural network architectures, usually, that learn associated relationships between words. At inference, the models can take natural language input from a human and then generate predictions or responses based on the learned patterns and context. And one of the abilities that some of the abilities that large language models are most commonly used for are like recognition, generation, translation, summarization of natural human language. But I think today we will actually see more abilities being brought to life.
Yes, and we just want to highlight that these new models are not just fancy geeky tools, but actually actionable models that can have a real impact on a patient's life and on the clinical world at large. They're also they're being seen implemented in electronic health records, medical education, medical research, and also into chatbots, of course. And we currently have a spectrum of possibilities that we already have with large language models, but they will keep on evolving, and it is up to us as healthcare professionals, as engineers, to help think about the future and what we could achieve using these models.
We also wanted to give you one example of what an innovative interaction could look like with a large language model that you don't see on a day-to-day basis. And well, one of the things I really enjoy doing is prompting GPT, for example, to basically be my sparring partner or to actually simulate a discussion to then carve out the key questions that we would actually need to address. And I'm not going to go into details about the prompt, but just to see what one of the outputs could be. It's actually a simulated discussion between two clinician researchers that talk about the most groundbreaking use of LLMs, and one argues for personalized medicine, the other argues for public health applications. And even though their arguments may not be factually perfect, it is an interesting way of brainstorming and using these tools innovatively. And this concludes our very brief introduction. And we would now like to move on to an opening poll.
So there are some interesting results where we see that almost 50-50 people have used it in a non-professional context and also in a professional context, which is really interesting. And maybe some people would like to share how they use it in a professional context, because that will really open up to see what the possibilities might be. And then the most of you think that medical research and knowledge discovery will have the most significant impact for LLMs, which is also very interesting to see. Thank you.
Hi, good afternoon, everyone. So my name is Nabeel Seedat, and so together with Rob Davis, we'll be looking at this idea of clinical data quality audits and could LLMs enable this from a no-code perspective. So without data, of course, there can be no machine learning, there can be no analytics, there can be no statistical models built when you think of actually doing clinical research. And the challenges in medical data are often quite abundant and very impactful. If you want to get insights from data, you might have mislabeling in a clinical data set, such as the incorrect disease label assigned. You could have a mismeasurement of some biomarker itself. You might have noisy data from clinical measurement devices, or you might even have at a patient level underrepresentation of different subgroups, which might introduce bias into your data set. And this is just a small subset of things which you could find in your data set, but that actually might be impactful to you as a clinical researcher. So one thing we first want to highlight is something called DC Check, which you can find on the lab website, something to guide what data-centric considerations one might think about when they're wanting to do clinical research. And this is almost a framework to start bringing out these considerations of what should you think about before using a data set in the first place. But even at the case of actually just auditing the data set, it's just fundamentally quite hard because there's many tools developed throughout the community, both from a software side and a clinical side. And often these tools are quite hard to use. And we ask in this here, can LLMs really help ease the usage of data-centric tools? And we've developed a platform where an LLM uses data-centric tools developed in the lab itself to actually audit data sets for issues such as bias and issues such as mislabeling in data sets. So I hand over to Rob for the demo.
And the Schaar Lab Data Tools interface is a no-code interface that leverages large language models to audit your data sets for you. So we don't need to know anything about the nuts and bolts. The large language model goes away, calls all the functions we need to get the results straight away from this interface. There are two different methods available, data suite and Datagnosis. Let's start with Datagnosis. Now, if I upload a data set, for example, this COVID data set, all I need to do now is chat to the interface and it will do everything else. So if I just say what tools are available, then it goes away, queries all of the software and finds this description of the two tools we have available. Now, due to time here, I'm just going to cut to the chase and type in run Datagnosis on the provided COVID data set. And that's going to run, or even with a typo, it can work out what I mean, and it's going to run the default pipeline with all the default parameters to get the results. And we can see after training a model on our data set, the data points where the model is very confident and the data points where the model is very unconfident. So there are lots more where it's confident than where it isn't, which is great to see. But it's this area where we're not confident that we're interested in. If I click on this expander here, we can see the 10 patients where the model is least confident in its predictions. And by looking at the features here, for example, in this patient and comparing them to this patient here, we could see they have different labels. Does that make sense given their feature values? Do we think, looking at this data, that any of these examples are mislabeled, i.e. they have the wrong mortality label applied to them in the data set, given the features? So yeah, that's the first thing we can do. We can try and identify some mislabeled examples that if we flipped the label, the model would start to perform better because it's currently mislabeled and confusing. If we can't do that, and it's not always possible to be able to tell for certain if a data point is mislabeled. So if we don't want to do that, what we can also do is say these 10 data points, or however many, if we cut the threshold at a different point, we can say these data points are essentially unlearnable. If we collected more data, learned more about the distribution, maybe we could use them. But right now, with the data we have, these are unlearnable data points that are confusing our model. So what we could do is just remove them from the training set and then watch our downstream machine learning model increase in performance. So that's data quality. If we jump to data suites now, and I import a different data set, this time the adult data set, we can see we have the same interface, and I can just comment here and chat with the LLM and get it to run a different pipeline that will just discover issues with bias. So last time I asked what tools are available. This time we know we're looking at data suite, so I could say describe data suite in more detail. We'll have the little description in the what tools are available section. And yet we see there's a nice paragraph there about how data suite is working. But again, let's just cut to the chase and run the data suite on the provided help data set. And again, this is going to run with all the default parameters. We could chat to the LLM here and tweak things, but for the due to time here, let's just look at this example. And here are the results. We see this green region are data points where the model that's been trained above is very confident, and the red points are where the model is very uncertain, it's not confident at all. And so by comparing the centroid of the certain region and the uncertain region, we can see the types of patient that the model is good at predicting for and is less good at predicting for. And we see single white males versus married black females. It's a very clear bias. We do not want to affect any downstream models that we might want to use in a clinical setting. So what we need to do is go away and collect more data about married people, black people, females, and iterate this process again. After having collected more data, run the same pipeline and see, do we see such a clear bias between the uncertain and the certain regions? So that was a very quick tour of two different methods that we have and a no-code interface that pulls them all together. But hopefully you've seen that clinician researchers will be able to A, improve their data quality, and B, discover bias in their data sets. Thank you very much for listening.
Hello, I'm very excited to be sharing some recent work about how we can use large language models to create a novel interface between clinicians and digital technologies. Over the past few years, our labs developed a number of new machine learning methods and approaches. While all of these represent wonderful technological and methodological advances, ultimately, we want and need to use such models to improve clinical practice and have a positive impact on the healthcare system. So, how do we best use and integrate these models in clinical practice? The primary way thus far is using clinical demonstrators. These are typically web-based interfaces that enable clinicians to interact directly with models via a graphical user interface, or GUI, rather than using an API or code-based interface. Many examples exist, and so here is a diabetes risk score built using autoprognosis, and here is another from our lab for the active surveillance of prostate cancer. And finally, here is the interface for QRisk3, the current recommended risk score for cardiovascular disease by NICE in England. These interfaces allow clinicians to enter the necessary information and then display the model prediction, possibly along with other information. However, we think there's significant usability limitations with clinical demonstrators, and this primarily stems from the fixed, non-adaptive nature of such interfaces. It's very much a case of what you see is what you get with such interfaces, and if the information or functionality you're looking for isn't already provided in the interface, it's not possible to obtain this. I'm going to present a system that uses large language models to build a new dynamic interface between clinicians and digital tools. So in the current interaction paradigm, clinicians interact directly with digital tools such as risk scores, most typically in the form of these clinical demonstrators, as I've mentioned. So our approach, in contrast, places a large language model between the clinician and digital tools. And these large language models operate by using these digital tools and act to facilitate the interactions with clinicians. This enables dynamic interactions that can adapt to the needs of the user. It's scalable to multiple risk scores and tools, and allows us to query external information without having to update the language model itself. This also overcomes many of the problems around large language model hallucination, since the underlying information isn't coming from the large language model itself, but rather from the underlying tools, with the language model facilitating the interaction by selectively retrieving the necessary information and providing it to the user in a natural, easy to interact with way. I want to present two short examples of such a system. The first is for cardiovascular disease risk prediction. And for this, we provided a large language model with access to the QRisk3 risk predictor, a PDF file of the accompanying publication describing the risk score, and the NICE clinical guidelines for cardiovascular disease. In this example, we will demonstrate how large language models can provide a novel interface for cardiovascular risk assessment. We'll begin by providing the data for our patient John. For simplicity, we're providing this as an external file, but this could also be collected via a web interface if desired. We then ask for our patient John, what is his 10-year risk of developing cardiovascular disease? The large language model understands our question and uses the QRisk tool to calculate the risk for John, which estimates that his risk is 13.3%. Now suppose that the clinician notices that corticosteroids are included as part of the risk score, but isn't sure why this is the case. Instead of searching through the scientific literature, we can ask the LLM. Using the Show Source Information button that we've implemented, we can see that the model queried the QRisk paper to obtain this information, which helps prevent hallucinations and enables clinicians to check the source of the information that's being provided. Finally, the clinician would like to know what, if any, action should be taken next. The large language model searches the NICE clinical guidelines for cardiovascular disease risk assessment and reduction, and reports that the guidance is to recommend lifestyle changes and that lipid modification therapy is recommended given the patient's risk is more than 10%, as well as other considerations for the clinician. For the second example, we considered the task of diabetes risk prediction and provided the model with a diabetes risk score from autoprognosis, as well as a way of interpreting the model using SHAP values. In this example, we'll demonstrate a large language model-based interface for diabetes risk prediction. Again, we begin by providing the data for our hypothetical patient John. For simplicity, we'll provide this as an external file. We then ask for John's 5-year risk of developing diabetes. In this example, we're using a machine learning risk score for diabetes, developed using the autoprognosis package. The LLM uses the autoprognosis model together with the data provided and returns a risk score of 0.4%, suggesting that John has a very low risk of developing diabetes, which makes sense given John's normal HbA1c measurement. One of the major challenges with the use of machine learning models in clinical practice is engendering trust with users. To facilitate this, we've enabled the large language model to use methods from explainable AI to understand the predictions of the risk score. When asked which features were the most important for John's estimated risk of 0.4%, the LLM returned the most important features used by the model, including a graph displaying the Shapley values. Unsurprisingly, HbA1c and age were two of the most important risk factors. Additionally, the other 3 most important risk factors were blood-based biomarkers, namely serum gamma-glutamyl transferase, C-reactive protein, and cystatin C. All 3 are known diabetes risk factors, giving some level of confidence in the prediction of the model. Finally, we can use the large language model to answer specific questions from clinicians that might not apply to all, demonstrating the benefits of a dynamic interface. In this case, the clinician asked for more information on the explainable AI method used, Shapley values. The LLM used its background knowledge to briefly explain that Shapley values are a feature attribution method and that this method originated from game theory. Thank you for listening and watching these short demonstrations. I hope you found these interesting. If you want to know more, please check out our paper, and we've also open sourced all the code necessary to produce these interfaces. Thank you very much.
Thank you, everyone. We will actually continue with a very quick poll that is related to this demo we just saw on interfaces.
So it might be interesting to look at these results. In the beginning, we had everybody responding yes to the questions, but then no came out to the forefront, which is really interesting to see. So there is still some debate if this is the biggest problem for everybody. And then we see a heterogeneous result about the type of interface for digital tools. And it will be also important to take this to this discussion as well.
Thanks everyone for sharing your thoughts. And we would now like to ask the first of our panelists, Dr. Bill Weeks, to actually share some insights on what he's working on and on visions for LLMs in healthcare.
Thanks again for having me. It's great to be here. It's really impressive work that you guys just presented. That's astounding. So if I think about kind of how these large language models can be used clinically, I can think, first thing is kind of to try to mitigate provider burnout, which is kind of worldwide. And so just the simple backroom operations, right? And I'm sure you guys know this, but the very simple stuff, just to cover this and make sure it's articulated, letters and summaries and prior authorizations and referral information, all that can be done at an instant instead of taking a lot of time and dragging things out for providers into their evenings. From a public health perspective, I think, a number of things you've already covered, just kind of patient information. And I'm the medical director for Bing, and with Bing and Copilot, I think what you see is very, very different with these models, right? Is that you used to type in something, do something about my arthritis, and you would get 15 advertisements first, or a couple of pages of advertisements, and you'd have to sift through things. You wouldn't get kind of something that was helpful for a patient and articulated in a way that a patient could actually make use of. So I think the summarization of these is really tremendous, and that's the huge kind of advantage of them, I think. We're working with the WHO, for instance, in summarizing and analyzing information. They get information from all sorts of different sources across the world, stuff that's sent to them, just kind of scanning newspapers, scanning reports and things like that to, again, aggregate data. So it's a useful information where you can then identify the kind of location of epidemics and things that seem to be kind of out of norm very quickly, which dramatically speeds things up and reduces labor costs. We've also worked to train models in the US. There's something going on that's called the Medicaid redetermination. So during COVID, Medicaid, public insurance for the poor, was liberalized a lot. Now that COVID is kind of over, the emergency is over, they've restricted that, and we have 50 states with 50 different rules about Medicaid eligibility. And because of this redetermination effort, there's about 10 million people that have been kicked off of insurance. So we just trained, as an example, in Washington State, and we're very quickly able to get a very high-functioning application that helped patients kind of identify whether or not they were Medicaid eligible and could direct them to the right forms to complete. Something that the state could do kind of immediately, just that we did as just a proof of concept. Reviewing literature for providers or for researchers is obviously quite helpful. And I think the newer versions, if people had used the older versions, are much better at being accurate about citations than the older versions were. Importantly, using this, we're working with IHME, the group that does the global burden of disease, to see if they can broadly kind of search the literature, identify the articles in numerous languages that are relevant to whatever disease that they're trying to determine the global burden of. So again, minimizing the labor inputs necessary to review do the searches, review all the abstracts, and get focused on the ones that need to be included. We're also working with Kaiser Permanente on doing a similar kind of thing for guideline recommendations. So, typically you have guideline recommendations. They're kind of based on data that can be a little older because it takes so much time to go through the process of identifying the articles and narrowing those down. In our imagination, we can imagine that these will be greatly accelerated, and so that you could have updated information integrated into guidelines within kind of a year instead of several to 5 years old. We're working with the American Ophthalmological or Ophthalmology Association, I guess, to develop board questions with them to understand both how GPT models can do in passing boards, but also then to develop board questions and see if they're fair when compared to the board questions that are generated by humans. Again, there's a lot of time that goes into developing a board question for any kind of specialty. So could you use these as at least first efforts to really narrow down and save a lot of time and generate new board questions so that the old ones just don't get reused and people just don't memorize those. You brought up physician training and review and continuing medical education. I think just the example that you gave of an interaction between two researchers that might have different perspectives, interactions between hypothetical patients and clinicians in training could be tremendously helpful to teach clinicians a little bit more about how to be empathic, how to understand patient needs, how to ask questions in the right way, because you can get that immediate feedback from the GPT as well, right? And saying, hey, you weren't so empathic here, right? You didn't actually answer their question. And then in the future, I can imagine the training on images instead of just these models, right? So if you have an array of images, an array of reports on those images, to train the models on that, to see if the models could actually then just read and give a preliminary report based on an image in the future. I think that would be intriguing. Thinking about interoperability, which has been a real hardship for medicine, and trying to compare and collect data from across different settings. I think this can kind of address that, right? Because it can say this, this looks like a blood pressure, so it's going to be a blood pressure. So I think that's a very promising thing. And then the shared, and you kind of gave an example of this, the shared personalized decision making. So not just looking at something, say, here's my cardiovascular risk, but making actually the risk very specific to me, to people like me, because that's just an algorithm. So if we are collecting patient-reported outcomes, and we can then say, for someone who has my particular characteristics, given this array of outcomes and the risk score algorithm, what is someone like me anticipate to experience from a cardiovascular event kind of a situation, or even knee replacement or some kind of an intervention where there's preference-sensitive care, where the patient might reasonably choose just medication and follow-up versus an intervention. And I think with regard to like the cardiovascular risk assessment thing, I'm a psychiatrist by training, and change is hard for patients. So if we tell them, as the output was, these are the things you can do, these are the 6 things you can do, my guess is patients will do none of those, because 6 is too many, right? So instead, calculate for me the one that will have the biggest impact on my cardiovascular risk over the next 10 years. Tell me to start with that. And so prioritize for me. And we're actually doing this with not only for patient individual risk, but for cities across the world, to try to identify which are the social determinants of health that are most impactful on improving cardiovascular health for the population. Let's prioritize those, because if you give a politician a list of 15 things to do, they'll do none of them. But if you tell them these are the 2 that really matter, and make it kind of good enough for government work, if you will, not specific like a researcher would want, but we're going to capture a lot of the R squared if we get these 2 things. Like, let's start there and then think about other stuff later. So that's kind of my quick summary of the stuff that I think we're working on. I see promise in the future for these models.
Yeah, absolutely. We agree. That was also one of the papers that was highlighted previously. And now we want to go on and also try to have enough room for the discussion at the end, but quickly to Dr. Graciela, who will talk to us a little bit, very short, about LLMs, who will facilitate the interaction with clinicians and medical knowledge.
We are at Cedars-Sinai Medical Center, so definitely some place where we want to deploy and use some of these things right away. One of the things I like pointing out is that at this point, the large language models that we're used to are the ones we hear about, like GPT-4 and GPT-3, although they do really, really well out of the box, are not quite ready for prime time in clinical data. One of the main things I think somebody mentioned in one of the questions, hallucinations, and how do you check? They make mistakes. They want to please you. It's kind of long to explain, but basically they are trained with reinforcement learning, they're trained to make you happy. What is it that the user reading the answer is gonna like? That's literally how they train them, right? So, so maybe some of you have experimented when you ask a question to Chat-GPT, you get an answer. If you challenge it in a follow-up question, it will almost immediately back out of it. So it will like try to say, oh, I apologize for that mistake, and then try to put something else. So it detects this interaction, so you can easily like pull it, really, even if it's true, the thing that it's telling you, you can challenge it and it will probably find some alternative there. So understanding how they work and what they do is very, very important. I don't know if we have time or not, but I have that diagram that I sent to Tim, and that could guide some of these ideas, that the large language models as they are right now need more work, need continuous training with specialized information, because they operate on a given context. The parameters they learn are in this generic context of everything goes. And what we need is to sort of nudge them into the direction that we want and give them the capacity to understand that in this particular context, clinical LLMs, you need something else. You need to give weight to something else. So that's what's going to change it. Easy way to think about parameters and all this, for those of you not too familiar with it. Yeah, you can go all the way to the end. This is the last two slides. So what you need to think about is when you're making decisions as to where to go. You ask a friend, let's go for dinner, and they have certain things in mind about what they want for that dinner, right? So they might want something formal, something like chef prepare and so on, and you might want something else. So the way you make this and how you're dressed is that you're gonna go to a fancy restaurant the way you're dressed. So there's things that are weighted in your context that might be different between you and your friend, right? So it's the same thing. It's dinner at 7, and then you have like what kind of food and so on, and what kind of environment. And you make some weights based on your circumstance, and your friend put some weights to each of these things in his or her circumstance. And so those are the things, the parameters. So think language models now. If you have a language model in a regular a common use context, the weights about things are different than if you have a language model operating clinical records. So in this slide that we're showing, you can see that the general language models that we know right now are on the far left. They are fed by or built on, literally, all the publicly available data, letters, notes, open access books and articles, websites, social media, online free text. They threw in everything on the kitchen sink. They have everything in there. And so some people might think it's like, well, literature is already in there. Why do you need to like do anything about it? Why do you need to retrain it? So it's a mistake, because at this point, literature is weighted the same as websites, or weighted the same as other things. So if you want something that's tuned to the literature, then you need to give it more information. Say, hey, this needs more. The way we do that is to continue training, is mislabeled there. So we continue training a general LLM with more data, and arrive, and this data can include, in the case of the clinic, private hospital imaging data, some publicly available medical data, private hospital notes and letters, and create clinically relevant social media data even to give you the patient perspective directly. So if we're able to do that and contribute that, then you have a clinical large language model that is attuned to the needs of that particular environment. And then we can go and do some task-specific reinforcement learning to teach it the format. So in Chat-GPT right now, you can ask it, and we saw some nice demos about formatted data outputs. So you can ask it to write a letter, for example, and it sort of knows that format. So that was done through reinforcement learning. And so we can reach these task-specific large language models, which can take different forms. If you want to focus on the patient, you can have patient-centered applications of this with medical summarization of the current health status or the diagnosis or what to expect about what to expect next. Or like Bill said, is like, what's the most important thing I can do right now? Those kinds of questions now will be tuned and toned in a way that will eliminate some of these problems with hallucinations. So we can have chatbots for health status clarification. We can have quick questions, you know, like the things that used to take a long time for a simple question, like, how do I take my medicine? Do I take it in the morning or at night, for example? So now this system, this clinical LLM, can then make sure that you can do these things. In particular, personally, my lab is at Cedars-Sinai. I also have part of my lab at the University of Pennsylvania still, and over there in the UK at the University of York. So some of them are in the audience today. But so we work across this different spectrum of applications. I'll just give you a couple of samples. One is on antibiotic stewardship. So to help decide if and whether an antibiotic was prescribed correctly, was prescribed when adequate. We have genetic dysmorphism notes. So basically, when a child is seen, there's some particular physical characteristics that need to be noted when a geneticist is analyzing whether this child could be potentially have a genetic condition.
Some of what you said, I would like to move more to a clinical focus. But what you said very much feeds into that, I think, especially like having this clinic-specific almost training. And what I would like to ask to Professor Eoin McKinney as a first question is, do you think that LLMs could eventually render traditional medical guidelines obsolete, or like just providing more personalized, up-to-date recommendations by basically feeding on the current medical literature and the EHR data of the patient?
So there's quite a lot in that question.
Sorry.
Do I think that LLMs will make guidelines obsolete? Not in the near-term future, and I'll tell you the reason why. Whilst I think they have enormous potential, I think everything we've talked about is hard to quantify. So how do I know how good the summary letter that my LLM has just generated is? We don't normally quantify letters, so it's very hard to put a quantitative measure on how good that is and how good the letter is. It's hard to put a quantity on that at an individual level, on its advice. I think it's feasible that we may end up there, and it would be much better, but I think there are faster routes towards personalized medicine than using LLMs. We've struggled to get individualized or even personalized approaches baked into guidelines so far. In medicine, we still are at a stage of what feels like the Stone Age when we're talking about LLMs. We're still at the stage of general health condition guidelines rather than getting it down to disease subgroups, much less individualized recommendations. So that the step beyond that to using an LLM to do so, I think is further away still. But for me, it comes down to being able to quantify and therefore more easily regulate the input into an LLM, as we've just heard. Is it everything off the kitchen sink, or how do you actually quantify the utility and value of what it's learning versus quantifying its output as well? And those are the two key pieces for me. That doesn't isn't supposed to sound defeatist, because I don't think it's not that I don't think they're useful. I think they're enormously useful and have huge potential. But I think in terms of getting to the point of them being used as a guideline for individual patients, I think we're not close to that. Would anyone disagree? Feel free to disagree, Steve.
No, totally agree.
Also, please do ask questions in the chat so that we can feed them into the discussion. And Mihaela, I think there's something on treatment options, and it would be interesting to explore.
You are asking me that?
Yeah, yes.
Okay, so I will
Because I know
answer
that you're
very
interested in
briefly.
that.
I will answer very briefly, but then maybe I'll throw away the question back to Eoin. So definitely, as I highlighted in this presentation that my student and postdoc have presented, we believe that these LLMs could be used also as a way to invoke other machine learning tools or biostatistical tools. So clearly, treatment effect estimation has been a very big area in recent years where both machine learning and biostatistics have contributed a lot, trying to understand what treatment is best for what patient and when, and potentially what dose should one give to a particular individual, or even what combination of treatment. Such machine learning tools are starting now to become available, but invoking them for the patient in front of the clinician is hard. So in a similar way as Fergus has highlighted for the Curis score or autoprognosis, we can invoke such tools to really provide the information to the LLM, which is then provided to the clinician, and then the machine learning tool in synchrony with, in tandem with the large language models, could provide information about what features have been looked at by the conventional AI model in making this prediction. Also, what would happen if we do something else, so talking about counterfactuals, and think together about these particular scenarios in order to advise the best course of treatment for the patient in front of the clinician. But all of these tools will need to be thoroughly debugged and thoroughly understood. So where I see the role of the LLM is lowering the threshold of adoption of more conventional AI and biostatistics tools, and inspire clinicians to engage through the use of LLMs with these already existing tools. I don't know, Eoin, whether you have anything to add.
Yeah, I like the idea of them positioned as an interface between a clinician and the information that we cannot possibly retain in its entirety in our heads. And in many ways, one of the reasons I like that is that the idea of hallucinations or errors become less impactful if they're part of a conversation. So you mentioned earlier there that actually when challenged, they'll often reverse and back out of the position they've adopted. Well, that's actually quite a strong feature, because whether it's right or whether it's wrong, it becomes a discussion quite quickly. And that discussion itself is quite valuable if you're having a discussion around what the best option is. If you can chew through the possible options, that has value. Almost impossible to quantify the value, that's the second point. But being able to have that discussion is really, I think, what you're describing, Mihaela, not just being able to access the information, but being able to access the tools as well that otherwise you simply wouldn't. And that's true.
And maybe uncertainty estimation could be there as well, provided not by the LLMs, but rather by the more conventional biostatistics or machine learning tools, who could say, for this individual, we are highly not confident, or we are highly confident, and this is why, maybe. Sorry.
Yeah, and from a treatment effect perspective, it's almost always the case that we give treatments without really knowing whether the individual in front of us fitted into the trial upon which the treatment effect is based. So saying, actually, you know, what's the evidence for me giving this treatment, and would an individual like this that I have in front of me have been included in that evidence base? The answer will almost always be no. And therefore you realize the weakness that you're basing your decisions upon. So I think all of these are better ways of engaging with the information. The challenge, I think, is the quality of the information that goes in there. You really have to have the confidence, and you wonder if there's a halfway house between simply assuming that more is better and that if we base these LLMs on literally every piece of information they can get the hold of, I think having some sort of quality filter and including information that has some sort of validity may be preferable, or reduce the number of filtering steps downstream, maybe.
Yeah, I think we all agree that the known thing is garbage in is garbage out. So that's indeed a very good principle to hold on to. And I would like to throw the next question to Dr. Weeks, because he already addressed it really quick, but I would really like to address this because it's really important for a lot of clinicians, and it's about clinician burnout. And that's why we want to ask the question: what kind of documents and actions could automatically be created or done by LLMs, and eventually maybe followed by a quick human checkup, or not even without a checkup? What do you think?
Sure, I think so. Summaries of charts. So when you're a physician, you get a new patient, you sometimes will have a very extensive chart that will be very, very redundant. And to actually provide a quick summary of the chart and let you focus on the things that are relevant is very helpful just in interacting with the patient. In the US, at least, we do a lot of something called prior authorization. So if I want to give TEM a particular medicine, I may need to justify that to the insurance company. That's a hassle to do. I can just tell the LLM to do that. And I can tell GPT to do it, say, do it for you, and cite the most recent 2 articles, and it will do that. I think if I'm referring TEM to some other patient, because maybe I'm an internist and I want to refer someone to a surgical patient for evaluation, I can do, again, a nice summary, summarize TEM, summarize the reason from the chart that I want to send them to you, and then again, review all of this stuff. If I want to write Tim's mom a letter, or Tim's school a letter, or something like that, saying, here's how Tim's progress has been in whatever field that we're treating him with, I can do that very quickly, and even provide Tim a letter of, here's your status right now, here are your labs, and like we talked about before, these are the things, if I were you, to work on to improve the top 2 things to improve your health going forward, those kinds of things.
Yeah, I agree. And we also, that will be very useful. And we also have a very good question, a very amazing question, even from Danny in the chat. Could you maybe please unmute yourself and ask it to Professor van der Schaar, or I can also ask it for you. It's the same to me.
Yeah, can you hear me okay? Yeah. I'm just wondering how far we are away from routine clinical practice for the use of multimodal data in large language models. And by that, I mean, histopathology data, radiology data, spatial data with omic data and clinical data, to make diagnosis, to personalize treatments, and eventually perhaps even obviating the need for whole genome sequencing, because spatial data can actually tell us what gene mutations are just from the patterns in the spatial data. Is that 5 years away, 10 years away?
I will not make a prediction how far away it is, but thank you for the question. I think that, again, I'd like to highlight 2 parts here. Large language models are in themselves also able to invoke other tools and other machine learning tools, or other imaging tools, or biostatistical tools. So what is wonderful about them is that they can act as these orchestrators that could engage with a variety of tools from different domains to pull together data and jointly reason about this diverse data using these different already existing tools. So while the LLMs themselves may not have the power, I would say, to really aggregate all this information and build all this by themselves, they do have the power to invoke a variety of other tools that have maybe been trained and potentially verified and maybe even debugged very carefully in different domains, and allow them to jointly learn to reason on behalf of a particular individual. So I'm keep returning to this point of LLMs in themselves may go only so far, but what they have also as the ability is to invoke other tools or other expertise. And why not? Maybe they are also able to invoke another human being. So right now we only think about machine learning left by themselves, but I always find that as a patient somewhat scary. So maybe the machine learning, the LLMs could also invoke not only tools that already exist, but also a clinical expertise or a clinical expert to give their opinion if they are uncertain about the current prediction. So I'm not sure how far away they are, but I see them as a great advance in enabling us to build a diversity of tools to work in harmony to answer questions on basis of very different types of multimodal information. And finally, I think that they can be used to help with what we call in machine learning self-supervised learning, where we allow learning across different types of modalities. You mentioned omics, radiology, pathology, clinical data. How to learn across these different types of modalities in synergies is also a great frontier where the LLMs can help. I'm not sure if the other panelists want to say something about this as well. This is the machine learning view, but you may have a clinical view about how this could evolve.
I think it's interesting to consider the regulatory hurdles. Firstly, I completely agree with you, but having been involved in trying to implement a single technology, you want to take one unpredictive assay and get it in for a single goal-directed process. That's a tough process, and the requirements involved in showing that it's robust enough that it works, what its impact is, what its negative impact might be. To do that for a system that potentially invokes multiple other tools is challenging, particularly when it could be used flexibly. It could be used flexibly in many different contexts. How you can demonstrate its safety and validity in those contexts, that's a tough one, and it's one that it's new ground. I don't think there's precursor for that, so that's why I don't think we're close necessarily.
That's a very valid point. I was gonna say that there's a lot of and it's important. We try sometimes we start thinking or talking about this safety checks and regulations that hospitals have to deploy these systems as a burden. And I really believe that it does keep us safe, because you don't want to be the one getting a diagnosis of cancer that's not true. It has real impact in real lives, and so much as we would like to have all of this bells and whistles already in, I think this slowing down, at least in the part where you are like relying on it for diagnosis or relying on it to make decisions, those are gonna take longer. I think at the poll at the beginning showed that most of us thought that in research it will like make the greatest impact, and I agree with that answer in the poll. It is really, we have to look at the complete path from knowledge to decision making, and use our tools at this point, at the point where the human is the gatekeeper at the end. Like what gets to the patient is with your doctor. The trust, you put the trust in your doctor. And then the doctor can use these tools to get more information.
And actually, I'm so sorry to jump in there, but there's a really good related question in the chat about how we actually rank evidence, right? Usually we would probably rank meta-analyses highest, but do large language models, or could large language models actually rank the evidence that they base their answers on? Maybe Dr. Weeks, you may have some insights on that. I don't know.
I think it's more for Dr. Gonzalez, who I think exactly explicitly said that. That's what should happen, right? Because you're right. Right now, I'm waiting an advertisement or some kind of crazy conspiracy theory equal to some very good, well done meta-analysis, right? Which she's suggesting, which is exactly right. Wait the things that are relevant and proven differently than the trash.
I mean, to put that in quick context as well, the number of clinical decisions that are based on level A evidence, tiny. That's because that evidence doesn't exist. And it doesn't mean that we can only practice medicine on the basis of meta-analysis level evidence. So we've got to be slightly careful that we don't try and restrict ourselves to only the things we've got perfect evidence for, because we can't. Also, evidence-based medicine is a great concept, but we basically rank things into levels A, B, C, D. And those are extremely crude levels. I mean, yes, it would be a step in the right direction, but it also largely applies to clinical trials and studies where there are set criteria for how they should be performed, inclusion rates, numbers, power estimates, blah, 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 generalizability. But for non-clinical trial level evidence, that's harder to apply. And obviously LLMs are not being trained purely on clinical trials. There's a lot of other data that's relevant, and doctors aren't trained purely on clinical trials either.
Thank you so much, everyone, for all the very interesting discussion points we've already seen. Given the very big interest in this topic, we would very much like to continue this discussion in the future. We don't know yet what the exact topic will be, but it will be announced very soon. This current session will be up on YouTube as well in the coming days to rewatch it. Thank you so much to our panelists who really gave very insightful ideas and views. And again, we would very much like to continue this discussion in the future. Thanks everyone for joining today.